I want to welcome everybody to our first Sunday morning of 2024. Where did the last year go? Wow. We're going to be speaking today about the Topaz trial. And I want to introduce our guest, Michael. How do you pronounce your last name, Michael? Schwarzschild?
Yes, that works well.
That works well. Okay.
Yeah.
I mean, everybody mangles my name too. And the second speaker, I think you all know who that person is, so I'm not going to introduce myself. But it's kind of fun seeing my name up there. Let me introduce Michael. Michael is an MD, PhD. He's a movement disorders neurologist at Mass General Hospital and professor of neurology at Harvard Medical School. He directs the molecular neurobiology laboratory at MGH, investigating the reduced risk of PD linked to between dietary and lifestyle factors like caffeine and exercise. He leads the Parkinson's Study Group of North America, which is a network of 150 or so clinical research sites conducting PD trials, including Topaz. And he serves on the steering committees for PD trials, including Topaz, SPARKS-3, Orchestra, and a Cure Parkinson's initiative for prioritizing candidate neuroprotectants. So, and then Michael will talk to you about the Topaz trial. I will talk to you about my experience as a person with Parkinson's participating in the trial. So Michael, do you want to go ahead? It's all yours. Oh, and if you have questions, go ahead and put them in the chat and we'll monitor the chat. Otherwise, we'll probably hold them until after we're done speaking.
And thanks, Sharon. Good morning, everyone. It's a pleasure to join you in the Twitchy Women Sunday morning get-togethers. As Sharon mentioned, I'm on the other coast from her, at least, and that cozy blanket that someone was knitting looks like it would be a good fit for our scene here, where it's still snowing outside of Boston. And I'm just pulling up my slides. In talking to you about the Topaz trial, which I am an advocate for myself as a member of the steering committee, like Sharon. That's how I've gotten to meet Sharon. Also reflecting a theme that I'd like to highlight before getting into the details of Topaz, about how studies like this and really the broader prospects for a hopeful progress with therapeutics in Parkinson's rests on collaborations. You know, and this Topaz is a bone health study, so I'll highlight the unusual matchup of brain and bone doctors, but also just across all kinds of disciplines and all kinds of partnerships, including researchers and patient advocates, of course, participants in trials. Neither could happen without the other. And so Sharon's participation from a very early stage in the steering committee for Topaz is a reflection of a better study because of its benefiting from patients' voices in general, and then her experience in particular as someone with Parkinson's, but then even along the way, which isn't always the case, where a patient advocate on a steering committee for a study is actually in the study and informing the study as it goes along. So it's great that she helps the study that way, and also for the conversation today, where she'll be the far greater authority in many ways with a discussion. And as Sharon mentioned, if you can use the chat along the way, and if it's something pressing, she'll pause us. Otherwise, there should be plenty of time for discussion at the end. As mentioned, this is in my corner of the country here in Boston at Mass General is where I'm a clinician and investigator, and we have a little research laboratory program in the Navy Yard campus that's linked by the Zakim Bridge, which we've adopted over the years as a metaphor for translation, bringing the science towards therapeutics. And the first set of slides, as I mentioned, I think I'm going to try to highlight just a principle that's got a lot of face value of the benefit of collaboration, but it's a little counterintuitive in Parkinson's research. And it's one of the reasons that the Topaz study is so refreshing, because we're so siloed, even within medicine, and bone health is something that is you can't support your brain unless you have a skeletal system to walk around and hold it up. But as a clinician, we think very little about bone health or other domains. And this study just illustrates nicely, while folks like me and others in the leadership of the study live around the brain, cardiology, eyes, these just the sampling bones, as we'll talk about, are all parts of a healthy person. Movement disorders neurologists generally very rarely prescribe medications in those other domains, so we don't tend to think about it. So the idea that there might be an interface here where the lives of people dealing with Parkinson's could greatly benefit from therapeutics in these other domains is something that this study is making progress towards pursuing. I think up here there's just a little quote about east is west and west is east, and never the twain shall meet, from Rudyard Kipling. And there's this idea to just swap in brains and bones there. Again, very briefly, but from piecing these slides together from a prior talk where I partnered with a bone specialist who's on the steering committee with Sharon and me as well, Ken Lyles, I have just introduced again sort of the context in which Topaz was developed. So it's a bit of a whirlwind slide per contextual point about the history of Parkinson's, in which this trial is eventually embedded. The focus, understanding the symptoms, and how that led to understanding the pathology. And most of the treatments we have focus on symptoms of the movement disorder, where dopamine replacement is the main goal, but other brain difficulties, certainly as the disease progresses, become prominent, if not predominant, in terms of symptoms, and then even whole body features too. That again, as a movement disorders clinician, we tend to give less prime real estate, but if one can't sleep or has dementia or has fractured bones, they're no less compelling. And then just more broadly, Parkinson's therapeutics and research is focused on is hoping eventually to slow down the disease progression, if not prevent the disease. So here is just some context going back a couple of hundred years, and how things are really picking up in Parkinson's. So as you probably know, James Parkinson first described a couple of hundred years ago in England his features of the disease that eventually bore his name. And these you know well, just the core symptoms. One of the particular relevant ones here is, even though it's generally not present until at least a few years into the disease, but balance issues, postural instability, of course, which can combine with other progression difficulties to be the source of increased fractures in the disease. So yeah, about 100 years later, we understood that those features, at least the movement or lack of movement features, are owing to problems in this deep brain center, the substantia nigra. This is a picture of the substantia nigra, this upper portion of the brainstem in this lower image that shows this black stripe or this black substance, or the substantia nigra, that contains the dopamine producing brain cells. This lower strip was someone who passed away without the disease. In the upper strip, you can kind of see the blanching or not see the black strip so much because that person had Parkinson's disease. Here's that substantia nigra at the top of the brainstem, the hemispheres of the brain over top. And then this is that sort of same cutaway that we were just looking at in a section. And then it projects its innervation north into these brain circuits where the dopamine release facilitates normal movement. And then it was about 50, 60 years ago now that it was discovered that that brain region is missing its dopamine. And then most of the therapies that we have focused on replacing dopamine. Levodopa still, despite a lot of variety, is still the gold standard for treating the symptoms of the disease. Right. So, but then, of course, as the field has learned, but anybody with Parkinson's is greatly appreciated as time goes on. The disease is much more than just movement, lack of movement, dopamine sensitive, movement disorder, but under the tip of the iceberg there, all kinds of other brain systems and part and involvement outside the brain, and leading to this sort of general notion that if neurologists are somewhere here holding a leg, that there's all the other parts from the nose to the other end where there are symptoms of the disease, which we won't go into today. But this is, again, just to more illustrate that there are other features of the disease that are a great source of a challenge, of not disability, and understanding that helps us begin to direct treatments towards symptoms and non-motor features. And that's where, at least even in the symptom and this balance difficulty that I mentioned on the movement part, but also with other non-motor features like cognitive difficulties, can conspire greatly to increase one's risk of developing bone fractures. And that's where this alliance and this Carly Tanner, who's one of the two PIs in the study, is situated on the brain end, and then kind of mentioned Ken as a bone specialist, and bringing the two together for highlighting this, the rainbow of collaboration, and here in targeting the importance of bone health, which has really been essentially never studied by a Parkinson's trial in any rigorous way like this. And this was also, just to highlight it, this was topical a few months ago when Michael J. Fox had, in addition to highlighting some dramatic progress in the field, was also sharing how many bones he's broken recently, again reflecting this common challenge that people with Parkinson's are substantially increased risk for. So that's where the Topaz study comes in. And just before getting into the study, just to put a finer point on why bone health is the focus here, in particular in Parkinson's, since, as I think I already heard mentioned, people are familiar with osteoporosis, lack of bone strength being a general problem, particularly for women. That has its own treatment, and because people fall with Parkinson's, of course, it's inherently even more compelling to consider. But when you actually look at the background, at that increased risk, that combination is notable for the markedly increased risk in people with Parkinson's disease or other forms of neurodegenerative Parkinsonism, which we'll touch on, because this Topaz study, unlike most Parkinson's trials, is not restricted to people who have Parkinson's disease as the basis of their Parkinsonism, but other forms of related disorders. But anybody with any of those are at increased risk of fractures, several-fold increase, such that any fracture can be like, on a given year, about a 1 in 6 people actually getting a fracture, and hip fractures, which as we'll highlight, are even more notoriously problematic. Is a smaller chance, but still 1 in 20 in a given year, given that happily 20 years is not unreasonable, or more, with a diagnosis to live a full life. You don't want to interrupt that with a fracture, and a bad fracture like of the hip as well. And it's, of course, as one gets older, for multiple convergent reasons in one's health, the risk of fractures go up. And I mean, these are straightforward points, but they help set the stage for why this study was so important to pursue, and that in Parkinson's, in particular, that when one starts breaking bones, particularly hip fractures, independence is generally less likely, more difficult to maintain. It's more likely to end up outside one's home and in a care facility, and even survival is shortened after fractures. So that's the background. These are the logos, and highlight the institutions behind and the people behind it at the lead anyway. But this is an NIH-funded study, even though we're working with a drug that's manufactured by the pharmaceutical industry. This is wholly supported for the common good and taxpayers' money through the NIH, which is the main sponsor or funder for the study. And it's in collaboration with multiple organizations, notably the Parkinson's Foundation, which has supported the study, as well as part of the intake, and this group that Sharon had mentioned, I've been overseeing for a decade or so the North American Parkinson Study Group, which is a network of movement disorders, neurologists, and sites that participate in research that hopefully will improve the lives of people with Parkinson's. And we've partnered as well to help funnel and recruit patients. And this is Steve Cummings and Carly Tanner who designed the study. Okay, so the study itself is indeed to test whether a treatment, which is a standard osteoporosis treatment called a bisphosphonate and zoledronate. It's zoledronic acid, but one of my main one of my main impacts has been to try to highlight that it's actually called zoledronate, which doesn't sound as bad as acid to be taking. Even though the logo still has zoledronic acid. Anyway, it's zoledronate, which is a bone health medication, and to test whether, in Parkinson's in particular, people who go on it, just a single injection, who were then followed for at least 2 years, whether that injection, if they received in this blinded study, the active infusion, zoledronate, whether that leads to a reduction in fractures, any fracture, which is the primary outcome, or because of its importance, hip fracture as a secondary outcome, even death, given how large the study is and the evidence that this kind of treatment can increase one's life expectancy, is also an exploratory outcome. Of course, assessing the safety in the context of Parkinson's, even though it's assessed that it's a generally safe medication and marketed in the general public, it's never been tried at this scale in Parkinson's. So we always want to highlight safety, and that'll be one of the things we're learning about. And then one of the more interesting trial science aspects of the study is that it is completely home-based. So not enough people participate in Parkinson's research, which is necessary for the advances that we all want. And one of the challenges is because it's hard to get to these tertiary care centers with traffic and distance and the like. So the fact that nurses come to the home for the one intervention for the single visit, and that everything else is done remotely, is really a reflection of the COVID era and technology allowing us to reduce the burden in this kind of study. So the features, like any good study, it's a comparison in a blinded fashion to a look-alike, indistinguishable drug that's infused. Again, it's a one-time infusion of this medication, and let's see, and it's actually is it already? It's just about the largest randomized control trial ever done for Parkinson's disease. 1,700, I believe, is the biggest randomized trial, and we're about halfway there. So it's certainly designed to be a huge effort, and collaboration again with the Parkinson's community and researchers. So that is the general design of the study, and as much as it is one of the most inclusive studies to be designed, which will help it reach its ambitious enrollment goal, there still are criteria, mostly from a safety perspective, such that not everyone is eligible, but the vast majority of people with Parkinson's disease or Parkinsonism from other neurodegenerative diseases that include things like progressive supranuclear palsy or dementia with Lewy bodies and other things that look like Parkinson's disease, a very widely cast net. And as you, I'm sure, know, and it's at age 60 or older when risk of fractures clearly goes up. That's the majority of people with Parkinson's anyway, with onset typically around that time or a little bit older in general populations. And then, as I mentioned, for safety reasons, there are a few conditions that exclude people from participating. Well, certainly if one is already taking the medication or a medication like that for osteoporosis in the last 12 months, then that's exclusionary. If one has already had a hip fracture, that as well. And then because of a idiosyncratic side effect that is very rare, but is important to ensure it's avoided in a trial, can be a degeneration of the bone, osteonecrosis, it's called, particularly the jawbone. Anyone that's had dental work or major dental procedures within the last year or has that planned would not be included because of the idea of trying to reduce fractures which come with falls. People who are not walking wouldn't be eligible either, as well as a few other health conditions that are happily not that common, like kidney disease warranting kidney dialysis and a few other conditions. And it is in English at this point that the study materials are, and that consent, which has to be informed, are presented. So that is another restriction. And this is the just the call out. And there's many ways that Sharon can avail any of you to connect with the trial if you'd like to learn more about it for yourself or somebody else for whom you think it might be a good fit. So I think that's my last slide, highlighting the hominess here of maybe you can see Pepper, if I'm not sharing too much personal information, Sharon, about you, your dog in the background there. But ours have been mascots of multiple clinical trials that we've pursued. And I know that I'm just thanking you now, and there'll be time for further questions, but I think I get to turn it back to you, Sharon, to give a more personal perspective on the study.
Okay, let's turn off your screen sharing.
Right, thanks.
Thank you. Okay, I came on board about 2 years ago, and I was asked to take the place of another Parkinson's advocate who was going off the study. So I came on, and I had already signed up to receive the, signed up to the study, but I hadn't received the injection yet. So basically what happens is you sign up, you get screened. I think it was a telephone screening, I can't remember. And if everything's okay, a nurse comes out to you and she does whatever she does, and then you receive either the actual study, the zoledronic acid infusion, or you receive a placebo. You don't know which one it is. And it's a double blind, correct? Nobody knows.
That's right. Nobody speak of.
So that was probably in January or February of 2022. March 17th, I was in Chicago, and I remember the date because it was the day before my birthday. And we were walking to pick up the kids at school. It was a beautiful sunny day, unlike what you see behind Michael today. And I tripped. Sidewalk was maybe a gap that big, but my shoe caught and I fell. And I'm going to share my screen for a second if I can bring this up. Okay. Nope, that's not it. That's the wrong one. Hold on. Oh, shoot. Whenever I do this, I get to start shaking. Hold on. Let's try again. Where is my... Oh, here we go. And I fell and landed on my shoulder. So this was about 6 weeks after I received the infusion. And I'm thinking, well, wasn't this supposed to prevent this? But I fell really hard. So you can see I was just a total mess here. If we go to the next slide, there I was for the next 6 weeks or so, going to everything, but yeah, I think that's it. Oh, this was my arm afterwards. You can see the bruising went. It was really interesting what happened with the bruising, because when you're in a sling like this, the blood goes to here and then stops. When the sling came off, then the rest of my arm turned black and blue. And this kind of a fracture. All right, that's enough. You don't need to see that. Okay, but that kind of a fracture does create a lot of internal bleeding. And so, I survived that. I went on my, through my life, and everything was fine. And I went for an MRI, for a breast MRI, about 6 months later. I think it was about 6 months or a year later. And my doctor calls me and she says, everything was fine, but we saw something and we don't know what's going on. There's blood that looks like it's infiltrated into, in their sternum. I'm like, okay, well, I fractured my shoulder. She didn't know that. She's like, oh, thank God. Now we know what's going on here. Because it bled everywhere. I mean, it just went everywhere. So, but I recovered. I was fine. And I thought, well, maybe I failed this test. I don't know. So I went to the next Parkinson's study group meeting, I think it was a year later, and I told my story and I said, I failed. Yeah, and they said, no, you didn't, this is, we want to see what happens. And what they're doing is you record, you let them know every time you fall, and if you fracture something. And I did fall a year later. I tripped in Hawaii when I was walking to get a massage. Tripped on a stone right outside of the massage tent, literally about a foot away, and fractured a toe. That wasn't nearly as bad as the shoulder, but so I've had 2 fractures since. I don't know, like I said, I don't know which infusion I got. We can only make presumptions, but the good news is I went in for my bone density test and it showed no change over the last 3 years. So I don't know if it's working or not working, but it's worth trying it. We've all fallen, and how many of you out there have fallen? Raise your hands who are on the screen. How many of you have broken a bone since you were diagnosed? Just 1? 2? Yeah, 3, 4. Yeah, it's very common. Everybody I talk to has had multiple fractures. So, just think, if I'm walking on a sidewalk that is it's that big a rise, and I tripped, it could have been a whole lot worse. We're tripping on nothing, literally. And I've caught myself so many times. So it's really scary. And the thought that there might be something that can help us prevent these fractures is really a big deal. So, have any of you signed up to participate in the trial? Nobody yet. Okay. Oh, good. 1 person. Deborah. You're muted, Deborah.
I've actually gotten the injection quite a while ago. But my tail is not as nice as yours.
Oh, did you have a reaction to it?
I did. I had a reaction to the injection that was not pleasant. And so, but I still am happy that if I don't have I assume I got the medicine because I was so affected by it. But I think that I'm glad I still had it because maybe my bones won't break as easily, which is what I'm hoping happens with that. So anyway.
Yeah, I had no reaction to the injection at all. They gave me some Tylenol to take. She said take Tylenol for the next 24 hours or whatever, and I was fine. But yeah, so your experience is very different than mine. Have you fallen since?
No, I haven't.
No.
So
Good.
I have nothing to tell.
Okay. All right. Well, I'm hoping I don't break anything else. I'm through falling. I've decided that's it. No more falls. So anyway, we're gonna let's open it up to questions. We've got a lot of time, and then we want to show a video that Michael was involved in. So Eileen, and then Susan, unmute yourself.
I'm not muted. Eileen, you're first.
You're muted. She's muted. There she goes.
Is this a one and done shot? Is it a yearly shot? And how does this medication differ from any of the other medications that are currently on the market?
You're muted, Michael.
So I guess we'll figure out how to field these together. But if it's more medical, even though I'm not the bone specialist on this end, it's a very thoughtful question, and it is set up as a single injection. I mean, these medications are already pretty amazing in that they are given for at least a year apart. Actually, I'm not even sure whether the standard is 2 years apart or just 1 year apart. I think it may be yearly if you have osteoporosis, but here it's for 2 years. And there's evidence that it lasts at least that long from a single injection. And so the treatment is a single time point, but the commitment to participate is 2 years. It's a pretty light commitment because you can, hopefully you'll get out of your house for other reasons, but you don't have to get out of your house for the study. It's as Sharon said, it's done by survey, and even the fractures, I believe, are also collected through the healthcare system, in addition to one's reporting if one's had a fracture. So yes, it is one and done. There's actually been a discussion as to whether it should be extended, or a second shot be provided, but the commitment, it looks like it's going to stick with just as it was described, 1 shot, 2 years of follow-up. Then how does it compare to the other medications? Again, there are a range of medications. They're generally reserved, the stronger ones like this one, for people who have osteoporosis. Some cut off on the bone scan that shows there's such, thinness or brittleness of the bones that one's at high enough risk that they call it osteoporosis. At a very basic level, I believe there's normal bone strength, there's osteoporosis, which is weakened, and then there's osteopenia, which is intermediate, that suggests a little bit of loss of bone mineralization, but not enough to warrant these kinds of medications. There are several kinds in this class of bisphosphonates. There are several. They are generally indicated if it's so severe that one has osteoporosis, but most people don't. And this study does not check a bone scan. If one is already on by their standard of care from their clinician because of osteoporosis, presumably these kinds of medication, they are ineligible. If they wouldn't have been on anyway because either they haven't been checked, or it's not a concern, or they don't want to be on, that they didn't want that level of care, then they would be eligible to enroll. So we're not measuring that and then making a determination. Only if they're not on those medications, then they get randomized.
Thank you.
Yeah, I'm not eligible, but I would do it if I could. And number one, number two, yeah, well, they get me for others. But if I missed it, Michael, what's the timeline for the conclusion of the study, and when will the preliminary results be in?
Yes, is Susan, is it?
Yes.
Yes. So a very thoughtful question, and reflects part of the partnership that overall historically is generally neglected as for partners, is keeping people informed and knowing what the timeline is. So of course we can't inform people, at least at the beginning of the study, of which drug they're even taking, because then it wouldn't be blinded. But at the end of the study, there's an obligation to share the results. Generally, and even sometimes what someone was randomized to. Generally, that information isn't shared until everyone is out of the study before we share the results of the study, partly because the study is blinded until the last person is out. So it's 2 years that one would be in, but because the actual enrollment takes years, and in fact is taking longer than initially planned, if one enrolled at the very beginning of the study, which was like at least a couple of years ago, and then finished 2 years, one might have to wait 3 more years. So it really depends when you're enrolled. At this point, we're hoping we're getting towards the latter part of the study, but it would still be several years before anyone, including the investigators, would know the results for the group. Of course, it'll be published in a timely way, and I believe there are plans then to share with all the participants what the results of the study are. So yes, as partners, that would be shared, but it would take a few years.
I'm at the end of the 2 years, so I would probably get a survey to fill out, I think, at the end of the 2 years. I'm approaching the anniversary. But I have no idea which injection I got.
Right, and that's a good sign. Although Deborah, in a doubly unfortunate way with your experience, there's a good chance, although it's not 100%, that you were unblinded by having a reaction. Of course, you can have a reaction to just the contents of an IV infusion bag, so it doesn't prove it. But that information Yeah, so Sharon, I was wondering, for both of you, really, whether you were told that you will be informed as to which of the treatments you were on after you finish, after the study closes, or never.
I don't remember.
I don't remember either.
Okay, well, hopefully someone has thought about that, even though there's a lot of details to remember. Generally, it should be as soon as possible, if it's feasible. And this to me, so here we are, at least a couple of people involved in the design of the study, and we're not even sure. But just as a matter of principle, I think it is good to share the information that's shareable, and particularly here where, with one's own doctors, after you complete the study, you might want to decide to go on therapy. It might be helpful to know whether you were on an injection of standard medication 2 years ago or not. So I hope, I trust that you will be informed as is reasonable before long.
Yeah. I mean, I told my doctor that I was in the study, and she was happy that there was I have osteopenia. There was no progression. So we're not doing anything at this point, which is fine, as long as I don't fall and hurt myself again.
Right. And to me, everyone's care is different, but that sounds to me like you have a good rapport with your primary care physician there, and you have an increased risk because of some thinning, but not enough for these kinds of treatments. And in some sense, you're the ideal person to be on it. Again, we don't know what you got. And as you had mentioned, it was right after you went on. We're not even sure exactly how long it takes to kick in. We will learn from your contribution to be sure. But it will be interesting to see how what you're treated with, how it will affect the disease.
Yeah, I think when I fell, it was about 6 weeks after the injection. So, and if I remember, they don't expect it to become fully effective for at least 8 weeks.
Right. So yeah, I mean, we're not going to figure out whether the study worked or not from your suboptimal experience in terms of breaking anything. If you were assigned to placebo and there really is an effect, you may be contributing to that difference. If it does work, and it works in 8 weeks, as you say, that separation of the two groups might not be apparent until after 8 weeks, and you may contribute to clarifying that. If it doesn't work, then that is good to know as well. But by the nature of a study like this, an individual story is not enough to draw any insights, and that's why this will be the largest study ever, because it takes, with a fracture rate of less than 10% expected over a year or over the course of the study, you would never be able to rely on 1 or 10 or even 100 people. So it's all those stories and all that math averaged out that's going to answer the question.
Susan, before I get to you, Ginger had posted a question. She's taking Fosamax once a week. Does this mean she's ineligible? And if she stops taking Fosamax now, will there still be time to join?
I think you are ineligible with Fosamax. You wouldn't if there's a reason to be on Fosamax, it wouldn't be appropriate to stop taking a necessary medication. But if it was marginal that you were on it because it was osteopenia, for example, there may be, with your primary care physician, a reason to stop it. But I believe it's a year off of these medications before you would be eligible. So that would be a fairly heroic effort to try to get into the study. It probably will still be enrolling in about a year from now, but you have to base it on your good, sound medical care for these kinds of decisions.
Thank you.
Susan?
Yeah, I'm really curious why in the criterion in the study you guys didn't include bone scans, because it just seems like it just seems very incomplete to do a study with this without bone scans. Beginning and after, because you're just talking about,
Yeah.
almost I just lost the word, but, statistics without facts.
Well, it's
Anecdotal.
less informed. I think it's a very thoughtful question, and both Sharon and I didn't actually address these questions. Neither of us were involved back then. But my understanding is that this is in part to try to give guidelines in a way that is not technology driven. As I mentioned, it's done remotely as is, so it's sort of a low touch. And the idea would be that you wouldn't need a special study to know whether, if it turns out that it helps everyone or everyone enrolled reduce fractures to a substantial extent, it could be the basis of a recommendation if you don't have osteoporosis, whether or not you have osteopenia or not. But honestly, and you're asking the question so thoughtfully, as a scientist, I would like to know that information because it is possible. It's actually maybe a very reasonable hypothesis that if it does work, it works mostly in the people who already have a little bit of loss, but not osteoporosis, and it doesn't do anything if you don't have any weakness of your bone. I think my understanding is that the medication strengthens bone even if you don't have osteo. A bone scans evidence of weakness. It just makes your bone stronger. So it may very well help in people who don't have an abnormal scan. But that's a lot of hand waving on my part. I think it's just for the generalizability and the cost of the scans and the simplicity that it wasn't included. Sharon, do you know any better on this?
No, I would imagine I mean, it's expensive to do a bone scan, I would assume, at the onset and then at the end of the study.
Absolutely, but it just seems, well, it's none of my business because I don't qualify, but.
Well,
it
but
just
it's a
seems-
good question, Susan, because
Yeah, it just seems you
if-
could do a complete study with a whole lot less people if you had not just anecdotal experience, but medical, facts of bone scans. You could probably get the same results with 300 or 500 people to find out.
Yeah.
maybe that's the follow-up.
Maybe.
Yeah.
But it's none of my business.
Oh, it is your business, and it's very thoughtful. And if they ask me next time at an earlier stage, I would ask the same question.
Yeah, we'll tell them I said so. That's all.
Get you on the next board, the next studies.
You bet. It just
You and
seems.
Sharon.
Maybe you have a bone density test required as part of to be eligible.
Right. I think the reason why I think it's such a good idea is because there's more information. I don't think it would necessarily have led you to exclude people who have a normal scan, but just knowing what they had when they started will allow you to stratify the results into those who did have a normal scan or had a slightly abnormal one, because you might find if there is benefit that it is in one group, and you actually might even find that you don't see a benefit unless you look at that one group. Because it may be, like in precision medicine, something where the benefit is only had by a subgroup. This is an intuitive one, people who have thinning of their bones, but we're not measuring it. So it seems like a very
Michael, would it be possible to ask people now if they had a bone scan, if they've had bone density tests in the past, what their bone density test showed? I mean, you should be able to get that information.
Yeah,
and then if they follow up. I mean, as a woman who goes to the gynecologist once a year, I'm supposed to get a bone density test, I think, every 2 years. So, most of us have had those tests. It might be worth.
I mean, I'm also deferring to the fact, as I've already mentioned several times as a caveat, that there are really super leading experts in bone health who are design the study. But I have a little notepad here, and both Sharon and I know on the steering committee Ken Lyles, and he loves to educate us. So, and if we can educate him, great. If it's something for the next study or for adding it on late. But I suspect there's a good reason, since it's such a good basic question. But allow me to ask Ken, and Sharon and I will at least find out. Maybe Sharon can relay the result to you, or the response.
Yeah.
Yeah. Because I think
Yeah,
Sharon,
how many of you on here have had a bone density scan? Everybody.
All the
You know,
women,
yeah,
most.
so it wouldn't be hard to get those results. You know, pre injection and then 2 years later, you know, after the next one, it wouldn't be hard to get it.
Yeah, frankly, I'm not sure you need the follow-up because it's known what the drug does to strengthen bone. But just to know who to give the drug, if there were an effect, or if the effect is different depending on what window of result, that would just be useful information to know. And even if it was too expensive, if those scans are available on the average, particularly women, 1 out of 3 or 2 out of 3 people, then why can't that be recorded and where it's available to secondary analysis of all the results.
right, and you'd want the after scan also, because statistically, most women have a certain amount of bone loss after menopause, no matter what. And secondarily, you could statistically figure what the average amount of bone loss is versus what the average is once they are taking the drug from their.
Yeah. Yeah, no, I was just, if it's an expensive scan, I'd rather have the first one rather than the last one. But then there are a lot of other covariates just on the science, ever so briefly, even less expensive. Are you on hormone replacement?
Right.
Is there a family history of bone fractures? All kinds of things that, having your DNA, because there's all kinds of these days genetic leads, and you could stratify for those. It could be just in somebody who has a certain genetic form that this drug works great for Parkinson's.
Right.
So anyway, really thoughtful.
Eileen?
In what we were just saying, I think that the DEXA scan might not have been considered because the testing population also includes men. I mean, amongst us, we have background with this test, whereas men usually don't get it. So taking that into consideration, maybe the whole thing would have been skewed by having maybe 50% of the testing participants totally out of the realm of getting that test. And again, the expense of then having all of the male participants taking the test in order to get a clearer picture. I mean, if you ask this only amongst women, I can see why isn't it included?
Yeah, but Eileen,
My
that's
question is, well, but what's the percentage of men and women in the Topaz study?
That's a good question. I think it's slightly more men than women. It's 2 to 1, 1.5 to 2 to 1 men to women in Parkinson's in general. But it may be enriched relatively for women. So I think it's similar, and it may even be that there's more men than women, but it's a big enough proportion that doesn't sound like a good reason personally that women are only half, so we're not going to do it optimally for women. No, I think the finances could be a reason, but it still sounds like a good question to ask. So maybe on the next Twitchy Women session, Sharon can report back on these good questions, responses.
Yeah, when I get some more information. Okay, Carol, you had your hand up? No? Okay. Well, I want to thank you, Michael. This was terrific. And I don't know where the other 40 people are that signed up, but I think they're going to be watching it on video, which is fine. And we hope to encourage everybody to participate in the study. When I send out the information tomorrow, I will have the link to the study for everybody so that you can, if you want to sign up, you can. One of the things Michael didn't talk about was he likes to play with lyrics. And he changed the lyrics to the song Rocky Raccoon for the Parkinson's Congress. We have a little video we want to show you that his children were involved in producing. And let's see. Ashlyn, can you go ahead and bring that up?
Yes, give me one moment.
And I'll take that technical transition here to time to thank everybody for inviting me into this discussion and for the thoughtfulness of everyone with all your questions. And good luck with the program and the like.
Thank you. Okay, here we go. This is a surprise to all of us.
And I'm welcoming you to the World Parkinson Congress. Many years ago when I was at school, my best friend was called Ivan Vaughan. And he and I were great buddies. And in fact, Ivan actually introduced me to John Lennon. So Ivan was a very important person in my life. Unfortunately, at a very early age, he contracted Parkinson's disease, and I saw the whole thing happen, and it was really sad when, aged 51, he died. So it still hurts to this day to think about it. But, however, my friend Michael has done a version of my song, Rocky Raccoon, and he's called it Parky Raccoon. And it's very good, it's very funny, and gets over the message. So, we'd love you to have a look at it, have a listen, enjoy it, and enjoy your time at the World's Parkinson Congress. Thank you.
Somewhere in the black pigment cells of Niagara, there lived a young boy named Parky Raccoon. And one day, dope ran out down the drain. Hit young Parky in the brain. Big Parky didn't like that. He said, I'm gonna block that drain. So one day he flew into Spain, booked himself a room in a conference hotel. Parky Raccoon checked into his room, only to find symptom treatment. Parky had come equipped with a drug to block off the path of his cell death. That cell death, it seems, had dampened his dreams by making his neurons act screwy. His name was a sin, and he formed fibrils thin, but everyone knew him as Louis. Now he and some jerk who called himself Bert were in the next cell in his circuit. Parky burst in and grinned at a sin. He said, Louis boy, this is a showdown. But Louis was hot, and he drew first and shot, and Parky collapsed in a synapse. Yeah, yeah. Now the doctor came in, aiming for sin, and proceeded to set up a trial. She said, Parky, you need to enroll. Parky said, Doc, I'm up for this goal. And I'll give consent, Doc, as soon as I'm able. And now Parky Raccoon was over the moon, excited to test bronchitis. check out, and he left it no doubt to help with his neuron survival. Hey, come on, party now.
You're muted, Sharon.
So what'd you think?
It was adorable.
Yeah,
It was
it was a
great.
lot of fun. And he had the dancing parkies in the background.
Yeah.
So,
Thank you.
all right. Thank you, Michael. It was wonderful. Chinona, did you have your hand up? And Ginger also. Did you have questions? Okay, Ashlyn, can we go to slide? So last month we had 2 speakers and both of them canceled at the last minute. And next slide. I think it should be on the next slide. No, oh. Okay. This is okay, there we go. So in 2 weeks, we have Sydney Collin returning, and everybody really enjoyed her. And she's going to be talking about freezing and falls, which is a good follow-up to this topic. February, we have both of our December speakers have been rescheduled. Amanda had from Strive PD came down with the flu the day before she was supposed to speak and had no voice. And Karen's mother unfortunately passed away the day she was, that morning or the day before she was supposed to speak. So we had to cancel both of those. They're both rescheduled for February. Okay, next slide. Okay, let's go back to the other one, the Parkinson's. There we go. You may remember Robert Cochran spoke to our group a while ago. He leads improv classes that are a lot of fun. And if anybody is interested in improv, I can give you well, you can go to the website, Yes and Exercise, and you can find out about them. But he's starting a special program actually a week from Tuesday called Day One, the Parkinson's Prison and the Hero's Escape, Journey to Escape. He's been running this program for several years, several times now. And it combines improv and writing and really focuses you in on your story and on your journey. So he asked me to publicize this because we have a class, he has a class starting next week or in 2 weeks. And you just go to yesandexercise.org/Shawshank. And you can get all the information. This is a screenshot, so I can't show you any, there's no links on here. But yeah, just go to yesandexercise.org/Shawshank if you're interested. Okay, and let's go back to our, okay, so if you are not signed up for the blog yet, please sign up for it. You should all be receiving it anyway. I'm trying to send it out to everybody on the Sunday morning group. And if you're not signed, if you're new to us and want to sign up for the to get our weekly newsletter, go to twitchywomenevents.com. Oh, that doesn't sound right. Anyway, there is a sign up on that on the website for that as well. Yeah, next slide. If you're in need of a t-shirt or a Twitchy Woman mug, we still have, they are available on my daughter's website, which is sweetpoppylane.com if you're interested. And next slide. We have a wonderful, wonderful peer mentoring program. Susan, who has been very vocal today, is very, very involved in that program. She's one of the people who has helped to develop the program. If you are new to Parkinson's, have relatively new diagnosis and we're looking for someone to talk to, please go ahead and fill out the form on the website and we will assign a mentor to you. Or if you are somebody who has a lot of experience and wants to share your knowledge with somebody newly diagnosed, we'd love to have you as a mentor. You can always use new mentors. Are any of you participating in that program now? As a mentor, Donna, are you a mentor? You're muted. No? Okay. All right, so, anyway, that is pretty much it, I think. I don't think is there anything else? Oh, we have our Tuesday morning chat that is open to everyone. Our Twitchies Without Partners is on Sunday mornings before our regular program. It's just, so it's about twice a month. And we've just added a Care Partners Facebook group. So if you have a care partner who wants to get involved, we can hook you up with put them in our Facebook group. They just have to email me and we can give them the information, or look for, I don't know what you look like, Twitchy, go to Twitchy Woman. I'm not sure where it is. And I think that's it.